So let's move now to actually treatment. We have four main comparison studies that came out recently. You have the CAT, the IVAN, the MANTA, and VIEW studies, which had comparisons between different anti-VEGF drugs. Who would like to summarize CAT? Anybody? And you can add to it later. You don't have to remember all the numbers.
Okay. So CAT essentially showed that monthly injections of ranibizumab versus bevacizumab equal approximately the same visual result at the end of 1 and 2 years. In the PRN-treated group, which began after 1 injection, the bevacizumab group did not show non-inferiority. It actually was inferior to the monthly injections, where ranibizumab gave a better result. And as has been pointed out, the other findings were the OCTs were improved in the ranibizumab-treated arm that was receiving monthly treatment versus the bevacizumab-treated arm. And they seem to be fairly equal, except that the safety was brought into question because in the first year, there was an increased signal in the bevacizumab group. And then it was, however, not felt to be related to any known complications from the VEGF therapy, so it was dismissed. However, that came back in the second year again to show a higher SAE rate in the bevacizumab group. And also, I think in the IVAN group showed a slightly higher rate, though IVAN looked at the systemic levels and found it to be much higher with bevacizumab than it was with ranibizumab. So certainly I think that the CAT trials showed us, that monthly injections of either agent given on the monthly basis yielded excellent results that seemed to be equivalent, and that if you gave on a PRN basis, you had to follow the patients every 4 weeks, and if you gave bevacizumab, they did worse than if you gave ranibizumab or if you treated monthly. The safety, I think, is really a question, though I can't find a biological reason for some of those events that occurred, and that's the problem. You can't describe why it's biologically occurring, but it's now occurred in the IVAN and both years of the CAT.
I think I agree with absolutely everything David said, but there's a couple other things that come out of the CAT study. One, the bevacizumab definitely doesn't dry out the retina as good as ranibizumab. So in a PRN basis, it was statistically needed more doses, and if you're doing treat and extend, that would be even magnified. So what it shows you is it definitely increases treatment burden if you're using bevacizumab. The last thing is I have a little hard time extrapolating any of the CAT data from bevacizumab to my clinic, because in CAT they used a FDA monitored fill and finish formulary where they put it in glass vials under nitrogen where there's absolutely no chance of getting infection or very limited. We saw even this week with the New England pharmacy fiasco where compounding pharmacies resulted in deaths from contamination of steroids. We've seen multiple cases of blindness from contamination from compounding pharmacies. There's definitely a higher risk using a compounding pharmacy of anything than it is coming from an FDA-regulated plant. There's also probably less efficacy in the Avastin we get in the clinic because of the aggregate proteins and such you don't see if you keep it in glass under nitrogen the way the drugs are supposed to be transported.
But I do think David brings up a point of this issue of compounding pharmacies because we were very much involved in testing the quality of the Avastin in the CAT study. And we did extensive testing on both bioactivity and aggregation and all these kinds of things. And it's really, it shows you the FDA required a lot of the testing to be done, which clearly the standard compounding pharmacy does not do. And again, we don't know what the implications are for clinical use in our clinics, but clearly in some ways the CAT is not real world. For example, I don't just treat 1 injection if I'm going onto a PRN or treat and extend. I usually give a minimum of 2, if not just 3 right off the bat, whereas in the CAT study on the PRN grouping, they only got 1 injection, and if they were dry, they didn't get the mandated 3, whereas in IVAN they did. So there's lots of things that, at least in CAT, while it was encouraging to show that there was non-inferiority in some cases between Avastin and Lucentis, as David points out, you know, in the clinic, the way we utilize it day to day, there are some differences.
Yeah, and getting back to the whole safety issue, I think when you talk about safety of Avastin versus Lucentis and Eylea and even Macugen, you have to, there's a safety of the drug itself in terms of does it cause systemic side effects. And there appears to be a weird difference that was seen in CAT, and certainly not an explainable difference. And even in IVAN, it was the opposite. I mean, Lucentis had higher arterial thrombotic events than Avastin in that study. But I think there's a second aspect of safety, which is what Dave and Carl just brought up, which is the whole idea of fractionation. You know, and there's you're basically taking something out of your control in terms of what you can do and what you receive. Are there things that you can look for in terms of pharmacy to ensure you get good Avastin, shall we say? And are there steps that you take to, for instance, ensure the sterility, to ensure freeze thaw, things like that, in your own offices to ensure that you're getting the best Avastin possible?
I think the first step is there are recommendations, as we said, from the Academy and from the Retina Society.
So 1/3 of states don't require you to wear a mask when you fractionate, right? It's not, I mean, they may do it, but that's not, and it's regulated state to state. There are some states that are just scary. And I wish there was a better accreditation process. I wish there was a way to buy it in glass vials. From an aseptic fill and finish formula, there's only one left. The backup to CAT, the one CAT had got shut down. And I think DRCR is going to use the other one. Is that right? Do we know?
No, I know the one that they used in CAT was shut down.
For a different reason.
But I think at a minimum, you've got to at least make sure that your compounding pharmacy follows those recommendations. I mean, there are some of the ones that had the issues before with the initial outbreaks didn't follow any of these.
And how about the storage of your Avastin in your clinics? Do you do anything special about storage? How long do you keep vials before you would actually consider, or syringes, I should say? And how do you store those syringes?
Right. Well, we really try to keep even though we buy in bulk, we keep obviously everything at 4 degrees right away when it comes from the compounding pharmacy, and we try to minimize the shelf life to somewhere at a maximum about 3 months. That would be the maximum shelf life, even though in theory you could go out longer. My feeling is, based on some of the stuff that we've done with syringes, that I think you can start losing some activity in a syringe with Avastin. So I think you have to be careful how much you buy, and being aware of how much you have on hand and how fast you're using it, and kind of replenishing it every so often. We try to do a good job at doing that and not keeping things around too long.
Yeah, one of the things we do at the clinic, which is something that would be very difficult in many practices, is our fractionation is done by our pharmacy. And under sterile hood, under using all the standard procedures. But in addition, every lot, we send out a random sample of syringes for microbiologic testing before we actually go on to use that particular lot. Ideally, we hope that the compounding pharmacies do that before they release that lot for sale. But does anybody go to extra step and actually test the compounded Avastin for
We did
microbiologic?
Initially, we followed the Baskin-Palmer, pharmacy guidelines and sent, some for culture, some for whatever it is, toxins. Antitoxins, what is it?
Endotoxins.
Endotoxins, yeah. And, at this point, I don't know any compounding pharmacy that does that.
There is one in San Francisco that does that. So there are a few that will try
Is that
to.
where you get yours?
Only under certain conditions we do get those, but it's unusual. It's very hard. I looked around, and there was only one that I could find that actually still routinely does that.